guidelines. From the glucose-centric approach, now the Thomas Kahn, as he said, the structure of scientific revolution, where we move from the paradigm shift, now from the glucose-centric approach to the cardiocentric approach. So more emphasis in the CV outcome, where you basically address the multifactorial intervention in the patient with diabetes, blood pressure, staging, weight reduction, and you use drugs that can influence or reduce the CV and renal events, and subsequently, obviously, they reduce HbA1c, which is most beneficial for the microvascular complication. And that led to the ADA, the American Diabetes Association guideline, that endorsed the SGLT2 inhibitors. But the earlier recommendation, 2016, it was basically about glucose lowering effect primarily. And later, the guideline with the more evidence coming into the shore, and now the 2020 recommendations, it also beneficial effect for the CV benefit on top of those patients with diabetic kidney disease. So what the ADA20 recommendation, that when you on top of metformin, once you have the indicators of high risk atherosclerotic cardiovascular disease risk factors or kidney disease or heart failure, SGLT2 inhibitors be recommended as an independent of baseline HbA1c or individualized A1c target. But quite interestingly, if all this robust data come to the shore, the ESC guideline for European Society of Cardiology in 2019 for treatment of diabetes, whether you are drug-naive patients or patient on metformin, the moment you have an atherosclerotic cardiovascular disease, they no more recommending metformin as the only first-line therapy. In fact, they go straight to the SGLT2 inhibitor as a drug of choice to reduce CV event in type 2 diabetes, and which should be prioritized. And this came from all the data, right? The strong data with the prevalence of the CVD and very high CV and CV risk patients, the beneficial effect of reducing the hospitalization for heart failure, as well as the CV death. In the ESC guideline, you can see the SGLT2, EMPA, CANA, and DEPA recommended in patients for the class 1A recommendation to reduce the CV event, and empagliflozin as a class 1B recommended in patient with type 2 diabetes to reduce the risk of CV death. So what are the future for the SGLT2 inhibitors? So what we have dissected from the EMPA outcome trial is that CV death and hospitalization for heart failure, it is beneficial whether you have a known case of heart failure or without known case of heart failure, it is beneficial. The second, we learned that regardless of your baseline HbA1c, the beneficial effect for the heart failure hospitalization and CV deaths is clearly been shown. And the third, regardless of the kidney status, whether you have a predictive normal kidney or your impact kidney, the beneficial effect being clearly shown of the CV deaths as well as the hospitalization of the heart failure. And it is clearly proven for reduction in the hospitalization for heart failure for the SGLT2 inhibitor as a class. In throughout the SGLT2 classes, all about 30% reduction in the hospitalization of the heart failure. So that led to the recent publication and the presentation late breaking trial in the recent European Society of